Hello, everybody, and welcome to this week's edition of It's Worth a Shot. Coming from you here from Alaska, Kyla Newland, account manager. And we have some wonderful guest speakers here today that are going to talk about NHSN antimicrobial use data. We can go to the next slide. So just our standard disclaimer that we have that when we have outside presenters that we're not particularly advocating for one partner or facility or entity over another when we have outside presenters. We're just bringing good information to you folks. We can go to the next slide. So just a few reminders of upcoming events. There is a COCA call tomorrow that's going to be focused on xylazine. If folks are have heard of that or are unfamiliar with that, it's something they're finding in illicit drug supply now along with fentanyl, and it is not reversed by naloxone like fentanyl is, and so it's kind of an up and coming topic. If you would want to tune into that, you don't have to register. This is just a direct link that we've provided, and then the CDC. NHSN surveillance up-to-date definition is basically if you've received a 2023 to 2024 updated COVID-19 vaccine, that's going to be the monovalent vaccine that we saw come out in September. And then also happening today and tomorrow is the ACIP meeting. And I looked at the agenda for that. They're going to be discussing COVID vaccine, RSV vaccine, pneumonia vaccine, as well as quite a few others. So we'll share that when we get those slides as well. We can go to the next slide. And also it is Shingles Awareness Week. So I encourage everyone to get their shingles vaccine. We know that shingles can be very devastating and long-term. If you do get shingles, you can get nerve pain, short-term and even long-term. And so it's really important for folks 50 and older to make sure that they get their shingles vaccine. We can go to the next slide. And then we've also got updates for some office hours that are coming up. These are going to be for NHSN. So there's one on March 28th and one on April 25th. So we'll continue to put that in our notifications, those emails that come out weekly for you to look and sign up for those upcoming events. Go to the next slide. Please add topics to the chat or put them in our evaluation, and please do fill out that evaluation for us. I see Mary has put that in the chat. That's really helpful, and we do use that to plan upcoming sessions. We can go to the next slide. Oh, we have a polling question. Have you done your healthcare professional immunization reporting in NHSN yet? So yes or no. And if no, do you need assistance? Mountain Pacific would be able to provide that to you if you do need assistance. Okay, it looks like some folks do need assistance, and we are able to look at those folks that answered the poll, and we can do follow up with you individually. Thank you for doing our polling question for us today. I'll give it just a couple more minutes. Okay, I think we can end the poll, Mary. All right, thank you so much for participating. Next, we'll have our weekly influenza snapshot. We are still seeing some higher flu activity in certain regions. So if you look at our region, we're still very high in Wyoming. We're looking less in Alaska, Hawaii, and Montana, but still seeing some activity. So just making sure you stay home if you're sick, get your flu shot if you haven't. It's still not too late, believe it or not. And we can go to the next slide and look at our COVID numbers. So COVID, we are seeing decreases in pretty much all regions. decreases in hospitalizations, emergency department utilization, and deaths. So that's a good sign for us this respiratory season. We can go to the next slide. And I will introduce our guest speakers from the Washington State Department of Health. We're very pleased to have them, and graciously they've accepted our invitation to present to us today. They're going to be talking about the antimicrobial resistance reporting in NHSN. So Jessica Ziering is an antimicrobial stewardship pharmacist for the Washington State Department of Health. She's board certified in infectious diseases, and has worked in pharmacy in different roles and settings for over a decade. She is passionate about protecting patients and communities from the unwanted consequences of antimicrobial use. And then we also have Katerina, who is going to be our main speaker today. And Katerina, I will let you introduce yourself. Thank you so much, ladies.
Hi, everyone. Happy afternoon. Hopefully, I think that's for everyone. I am the antimicrobial stewardship epidemiologist here at the Washington State Department of Health. And basically what I do is I take all of the different data and try to make it pretty and useful. Next slide, please. All right, here are pictures, just in case you wanted to see what we look like. We're going to keep our cameras off for internet connectivity. Next slide. All right, and the main purpose of today's presentation is to provide an overview of the primary antimicrobial use metrics that are available in NHSN and to kind of discuss their advantages and disadvantages. Next slide. Okay, so hopefully at this point, you're all aware that starting this year, hospitals who participate in Medicare's Promoting Interoperability program will be required to be in active engagement or have an applicable exclusion with the NHSN AUR module. So that's antibiotic use and resistance module. I linked a couple of FAQs on this slide, so if you have any questions about implementing reporting, those are some good resources. And I can also answer a couple of easy questions on exclusions if you do have them later. Next slide. All right, so the first step is, how do you actually get access to NHSN AU data? It means you need to have access to NHSN. So hopefully you or someone at your facility already has the facility administrator role. If you're a pharmacist or a clinician or an antibiotic steward who's going to be looking at this AU data, we recommend starting the process to get NHSN early, since it can take a few months to go through the registration and identity proofing process. Once you have that SAMS and NHSN account, you can get access to the data pretty easily. It's all located under the patient safety component. And before you look at any data, just make sure you generate new data sets. Next slide. All right, so one of the questions we get a lot is what is actually in NHSN, what gets reported to it. So NHSN takes all antibiotic use data from all inpatient locations, procedural areas, as well as emergency departments and any 24-hour observation areas you have. Much of that data is viewable by location or specific unit type. So it gets grouped into like ICU, ward, pediatric ward. And these locations are defined by NHSN criteria. And you'll want to check your reporting plan to see which unit is classified as. So some of the larger hospitals may have things that kind of could fall into a couple different categories. So check your reporting plan so that when you look at your data, you're like, okay, that's what's getting lumped into this category. And if you're confused on what a reporting plan is, typically your facility administrator, which is often your infection preventionist, is the one who fills that out each year. And we recommend that a pharmacist or a stewardship lead fill that report out so that your data makes sense and their data makes sense. Please also note that the AU module doesn't contain any data from outpatient clinics, even if they're affiliated with your facility. We know that it's a huge limitation, and hopefully someday we'll have better access to outpatient data. But for now, there's no outpatient data except for your emergency department. All right, next slide, please. And then we get a lot of questions about who can actually view your data in NHSN. So any other NHSN users at your facility would be able to access it. If you're part of a larger healthcare network that has NHSN data share agreements with your facility, they would often be able to see your data. So we see this if there's a centralized stewardship team or pharmacy team, or if you're all a part of the same healthcare network. And then the stewardship team at your health department may also be able to view your AU data. So if there's a data share agreement in place, they'll be able to look at it for quality improvement reasons. And then additionally, the NHSN AU and stewardship teams at the CDC would be able to view this data. Centers of Medicare and Medicaid does require you to report data to NHSN, but they actually can't access it. So NHSN will provide you documentation to show that you're in active engagement with the AR module, but it doesn't provide access to that data itself. And reimbursement is not tied to AU or AR metric performance. Next slide, please. All right, so if you've started familiarizing yourself with the NHSN AU module, you've probably heard about the SAAR, which is the Standardized Antimicrobial Administration Ratio. If you haven't, that's totally okay. I'm going to talk about a lot. The SAAR is what we like. SAAR is a cute, shorter, easier version to say. It's a summary measure, and it was developed by the CDC, and it was meant to provide a quantitative tool that hospitals can use to compare their antimicrobial use. So similar to a standardized mortality ratio, or you might have heard of a standardized infection ratio, which is another NHSN measure. The SAAR is a ratio of observed over predicted antimicrobial dates. And those observed is what you actually use at your facility. Next slide, please. So you might be wondering, what's a predicted antimicrobial day? How is it actually calculated? Oh, hold on. Go one more slide. There we go. Wait, go back one. I think they got a little bit out of order. Okay. Oh, okay. Well, we're missing a slide, so I'll just talk about what the content is. So predicted antimicrobial day, it's calculated by NHSN using a model based on nationally aggregated data of antibiotic use. So they went to a bunch of hospitals and they sampled their antibiotic use, and then they risk adjusted by taking into account a bunch of facility and location factors. So they look at your bedside, the number of ICU beds you have, what's your average length of stay? Are you a teaching hospital? They also looked at your location level, so it takes into account how many beds you have on a particular ward. If it's an ICU ward, is it an oncology ward? Is it a surgical ward? So they use all of those different factors to essentially risk adjust the model and create a predicted antimicrobial days. The one thing that's really important to remember is that these risk adjusted models don't take into account patient level or clinical factors into account. So they're not taking into account flu season. They're not taking into account whether or not a patient has COPD. So it's not a measure of appropriateness. The last baselining for these modules took place in 2017, and they are updating it this year. So if you start reporting NHSN data, you'll be on the new, next year, you'll be on the new baseline data. So it'll say 2024 model instead of 2017 model. Next slide, please. Okay, here we go. SAAR interpretation. So if your SAAR value is greater than 1, it means that your observed days were more than you predicted. And if it's at 1, it means they're equivalent. And if it's less than 1, you use less antibiotics than was predicted according to this module. And if you have questions on this, I linked a useful slide in the bottom of this slide here, or useful resource. I can't talk today. All right, next slide, please. Okay, so one of the most confusing things about the SAAR is that a value of 1 is not necessarily your specific goal. So we know that antibiotic use varies widely by state and region. So here in the Pacific Northwest, we consume a lot less antibiotics than other regions. So if we're comparing ourselves to a SAAR of 1, that may not be the best because what's our baseline is less than 1, right? We've seen a lot of critical access hospitals in Washington state that their SAAR values are consistently below 1 for majority of their drug categories. So to further complicate things even more, you may want to increase a SAAR type, so above 1. So if you're looking to increase narrow spectrum use, you might want to have a value above 1 while decreasing another SAAR. So we like to use it as a signal that something's off. So if your data, if you're using a lot more antifungals than other hospitals around you, that's a signal to look further and to check to see if it's appropriateness, if it's appropriate use. Next slide, please. All right, so one of the things I do love about NHSN and the SAAR reports is you have a lot of ability to customize those reports that you get out and the data downloads. So you can download all this data in a CSV file, you can run a HTML report, and you can also break all of that down by location. So if you're interested in the performance of a specific unit or a group of wards or your entire facility, you can run reports for that. You can also look at a variety of antimicrobial agent categories. So if you want to know about narrow spectrum beta-lactam use, you can look into that. If you want to know about all antibacterial use, you can drill down on that as well. And then NHSN lets you pull out a bunch of different time periods. So I listed them all here. We mostly look at annual and quarterly use, especially at smaller facilities who are not using as many antibiotics. That can be a little bit more useful. Next slide, please. All right, so this is actually what NHSN looks like when you log in and you click on the antibiotic use and resistance module reports. The SAAR reports are at the very, very top. And those, like I said, are used for benchmarking your antibiotic use. There's against yourself and against other hospitals. You can also get line listings, so you can pull out in like all of your antibiotic use ever. That's reported to this module, and we use those a lot. You can also look at rate tables. So that basically takes your line listing and turns it into a nice rate of antimicrobial days. And then you can also look at which antibiotics you're using more frequently. And then you can run pie charts and bar charts to look at that data in another format. And you can run these in HTML format and screenshot those reports to share with your committees, or you can download the data and manipulate it into like Excel or another statistical program. Next slide, please. All right, and I won't get into all of this, but these are your different antimicrobial agents and their prefix. It's just a nice little summary slide. This is all in the protocol, but if you don't want to look through the protocol, you can check here for what those codes mean. Once you get used to it, it makes a lot more sense. All right, next slide, please. Okay, so after all of that talk about SARs and SAR reports, here's what one actually looks like, and I'll break down some of the components over the next few slides. Next slide, please. All right, so this de-identified report is by location. So if you look at the location CDC, it's telling you that it's an inpatient ward. And then I made up some values here. So I have medical surgical unit and an ICU unit. And then what's highlighted here is the actual SAR values that were calculated for each of these units for those time periods. So as you can see, the SAR value for all antibacterial use in 2022 for this ward X was 0.786. So it was 21% less than your predicted days. Next slide, please. All right. And so the SAR reports will also give you p-values, which is a statistical measure that indicates if the reported antibiotic use is statistically significantly different from predicted. So it tells you, okay, so it's less than 1, but is it statistically significant then it's less than 1? And if it's under 0.05, we say that, yes, it is statistically significantly different from 1. All right, so some of you that are really into statistics will get into your p-values. We do show them on our SAR reports for Washington State. If you have really small numbers, you may not get statistically significant values. And the way to, if you want to get statistically significant values is probably to go to like up it time frame, so go from quarterly to annual. All right, next slide, please. All right, so one of the interesting things that has been added to the SAAR reports that will be most useful for you is these SAAR percentiles. So SAAR percentiles is how you compare yourself to national antibiotic or an antimicrobial use. So remember that the SAAR module is creating those predicted days, and it's based on a nationally aggregated data that we collected in 2017. So in contrast, the SAAR percentiles are calculated using the location-specific SAAR distributions for the previous year. So it's more updated data. So for example, a SAAR percentile of 50 is the median for that distribution. And on this report, that first SAAR we looked at was 16. So that means 84% of medical surgical units in the United States had higher SAAR values than this unit in the previous year, which was 2021. So this is another reason why it's important to check that your locations are mapped correctly in order for that percentile to work or make sense. If you had an ICU unit mapped as a medical surgical unit, your SAAR would be super high, even though it shouldn't, because it shouldn't be compared to other medical surgical units. It should be compared to other ICU locations. All right, next slide, please. And then ultimately, what can you do with this data? So I've mentioned a couple of different things so far, but what we like to use it for and what it's made for is inter-facility benchmarking. So looking at how two wards in your facility compare in performance. So that might be more relevant for larger hospitals if you have multiple medical surgical units or multiple ICUs. That will be useful. And then intra-facility benchmarking, it's to compare your facility SAAR to other hospitals. And we in Washington have a dashboard with this access. So we let our critical access hospitals compare themselves to other critical access hospitals, and our, very large, more than 400 beds hospitals compare themselves to their peers. That way, your data will make more sense, because if you compare yourself to a big facility when you're a small facility, you're probably going to use less antibiotics overall. All right, next slide, please. Okay, so here's a summary slide of the SAAR. The advantages is it's risk adjusted. You can do that benchmarking I talked about. And the disadvantages is it's not risk adjusted for those clinical factors or those patient factors. It doesn't measure appropriateness, and it isn't available for all unit types. Next slide, please. All right, so one of my favorite things in NHSN that's beyond the SAAR is antimicrobial days per 1,000 days present. As an epi, I really like looking at rates. And so this is, I think, such a great advent, and will let you drill down on whether or not your interventions are working. So there are other data options, but we don't have time to get into all of that. So if you have questions, you can let us know. Next slide, please. Okay, so antimicrobial days, it's a really simple metric. It's basically the aggregate sum of all of the days for which an amount of a specific drug was used and administered to patients, and that all gets documented in your EMHR system. And then it's over days present, and so it's the number of days that a patient spends in your facility at any time throughout a day during a calendar month. And that gives you the ratio. And I'll go over some of those technical definitions, and it's something that you'll want to review if you're used to days of therapy. So next slide, please. All right, so this is how they're calculated. So an antimicrobial day is any amount of specific an antimicrobial agent administered to a calendar at a particular patient. So in this example, amikacin was dosed intravenously every 24 hours, and that means 1 antimicrobial day. Meropenem was given intravenously every 8 hours, and that means it's 1 antimicrobial day. And then a day present is a count of the calendar days when a patient is present in a given location for any portion of the calendar day. So this is where it gets a little bit complicated in the math. an example I have here is if patient Testy Testerson was admitted to your facility on 12/28 and then discharged on 12/30, Testy would contribute 3 days to your facility-wide days present count. But if Testy was transferred from the medical ward on the 29th to another ward, they would contribute 1 day on that 29th to each unit's location's specific present day count. So this tends to overestimate the number of actual patient time in your facility. And if you're used to days of therapy, that tends to underestimate the amount of patient time in your facility. So they're not a one-to-one comparison. The really great thing about having a vendor and having software is that you don't have to do any of these calculations. This is all done for you, and it just shows up in NHSN. So there's no hand calculations, which I love. Next slide, please. So as I mentioned, the antimicrobial days are very similar, but not equivalent to days of therapy. One is an overestimator, the other is an underestimator. We can get more into that if you have questions, but for the sake of time, I won't unless you really want to know. I've linked a paper here that if you're curious about how this transfer between one to the other would look in your facility, you can read more there. All right, next slide, please. Okay, and then what can you do with antimicrobial days data? You can look at specific selected drug agents. So right here, super tiny, you can't see it, but I have cefepime shown. You can look at drug classes. So if you want to look at fluoroquinolone use over time, you can do that. And then you can look at drug categories, which is the least useful because it's antibiotics, antivirals, and antifungals. And it doesn't, if you're not teasing out the antibiotic use, it just looks super huge. You can also look at these two things at once. So we have our facilities look at, for balloon effects. So if they're really targeting fluoroquinolone use and targeting decreasing that, they can run a nice little trend line analysis, see if it is really decreasing over time. And they can also look at other drug classes that might be affected by their intervention. So if you're decreasing fluoroquinolones, you might be interested to see how cephalosporin use is changing. And you can actually do an analysis and see whether or not you've had an increase that's statistically significant in third generation cephalosporin use. So those are the things I really like. It allows you to evaluate your interventions and look at use over time. Next slide, please. All right, so here's a little summary. Here are the advantages. It's really easy to assess like the magnitude and change in prescribing rates over time, and you can do it by a specific drug or a drug class. And as I mentioned, you can look at balloon effects of your interventions. I find it's really conceptually straightforward and easy to communicate to stakeholders, a lot more so than the SAAR, which gets into ratios, and that takes a while for people to learn. So if you're talking to providers, antimicrobial days is an easier way to communicate that information. And you can also track antimicrobial days at the facility level or an individual unit level. So if you're concerned, why is our Zosyn use so high? Where is that Zosyn use coming from? You can drill down to the specific units in your hospital that may be contributing a lot of antimicrobial days. The disadvantages of it is it's still not a measure of appropriateness. It measures the quantity of prescribing and not the quality. So it is a good signal if you're seeing a high spike in something or an increasing trend. It's worthwhile to sit down with your stewardship team and to actually do chart reviews to see what's going on and if it's appropriateness, but it isn't going to return a quick and easy appropriate or not designation. Next slide, please. All right, and for further assistance, if you have SAMS questions, reach out to SAMS. That's when setting up your account. If you have NHSN questions, so if you're confused on whether or not you qualify for an exclusion to report to this module, or you're having trouble accessing something or there are errors in your data, reach out to NHSN. And then we did give that specific line for eligibility for exclusion. So reach out to them if you think that you may qualify. All right, next slide, please. And then I put a ton of resources on here. I did all the reading, so you didn't have to. These are all the different sources I used to make this presentation. And there is a lot out there. And I recommend going through CDC's NHSN training if you're just getting started with the data. It's very helpful. Next slide, please. All right, time for questions.
We do have one in the chat. It says, how are these AMU stays 1,000 per 1,000 going to look for cause when they have smaller numbers?
Yeah, it will look exactly the same. You might just have, I can actually show you some of our data for critical access hospital if you're interested in seeing some. Does anyone want to see that? You can shout out yes or no. Okay.
Yes.
All right. Great. I can't see the chat, so thank you for telling me. Will you stop sharing and then I'll share our dashboard, which contains all of our data. And let me find a critical access hospital to show you. Okay. All right. So this is what your data will look like. Okay, so this looks super messy because I have every single antimicrobial use selected in this facility. But what you'll be able to do is pull a report and you can select what kind of drug. So this is a critical access hospital in Washington State. It's de-identified. So no worries at looking at this data. And then you can look at ampicillin use. And so just like what you were thinking is there may be a little bit of a wonky trend here is you've got small numbers. So there are many numbers where you're getting 0 days. And so if you're just looking at it a monthly use, it's going to look a little choppy. If this was my data, what I would do, and everyone can see this, right? Because it's like,
yes, we can see
okay,
it.
great. Because I can't see if you see it. I would do is I would aggregate up to bi-monthly. So as I mentioned, NHSN gives you a lot of report options out. So you could run your NHSN report to give you bi-monthly, so every 2 months or even quarterly. So if you have small numbers, just aggregate up to the next time period until this data doesn't look so choppy anymore. And then you can still run a trend line analysis and look for changes. If you're at bi-monthly, it's still really nice because you can look at potential seasonal trends in use. We expect antimicrobial use to increase during respiratory virus season and specific drugs, but you can still run that trend line to see whether or not you've had truly a 10% decrease in ampicillin prescribing over time, or 10% increase if you're looking to improve the use of narrow spectrum agents. And then one of my favorite things to do is I like to look at everyone's fluoroquinolone use. So we'll go here. And we'll look at their fluoroquinolones. So this facility uses fluoroquinolones, and if you go up from a specific drug and you want to look at drug classes, that's another way to get around those small numbers, because you'll have quite a lot more antimicrobial days and days presence when you get a little bit bigger of a drug class. And so this facility has steadily been decreasing their fluoroquinolone use since they started reporting data, which we love to see. And we might be curious to see, okay, are you using a lot of cephalosporins in replacement? And we can actually look at that as well. So if I had this data in Excel, I would pop a simple little trend line on it and see if it's positive and what that slope looks like, and pop one on this one. So we do see that cephalosporin use is generally increasing if we're eyeballing this over time, and maybe leveling out as that fluoroquinolone use has decreased from its peak in 2021. Any other questions I can answer?
Looks like we had a follow-up question. Can you also send out the mentioned difference between DOT and days and 1,000?
Oh, days of therapy versus antimicrobial days. Is that what you're interested in seeing? Okay, yeah. We can spend a little bit more time on that. I can go back. I can share my screen actually. This will be Okay. So yes, all these links will be included in here. And let me present. Okay, hopefully you can see this. All right, so days of therapy, when you calculate it, days of therapy does a nice like, okay, you're in the hospital, that you have to be in the hospital at a specific time point in order to get counted. So you're going to get missed. Patients that are transferred between units are going to get missed when you do those counts. And those counts are typically set in your EMR system, and that pulls your bed counts for the day, right? And that's the major difference between days of therapy and antimicrobial days, is how they count that. So for days of therapy, it's your census at midnight, your census at noon, in a particular unit, and that's going to count for a whole day. Days present gives you, it counts partial days. So if you spend 3 hours in a particular ward, that gets counted as a whole day, even though you were only there for 3 hours. So that's why it overestimates time. So if you get transferred between 3 units in a particular day, so if a patient's going through surgery, they might be on 3 different units, right? You're going to have 3 days contributed to your overall facility use, even though your patient was only in those units for a portion of the time. So your facility day would just be 1 overall. For facility wide, those are calculated separately, but you'll actually get a whole day for each of those patients in those unit types. Is that making a little bit more sense? And if it's not, tell me and I will try to explain it in a better way.
Looks like there's another follow-up question that says, is this for observation patients or just inpatients?
It will be technically for both. So there will be inpatient measures, right? So all of that antibiotic use is going to get calculated, but 24 observation areas do get reported into NHSN. So if you have those data will be available and visible, and will also count towards your facility-wide use.
Okay, so looks like we ran over. If we have more questions, we can definitely get it to the presenters. If you guys just want to submit them to us on your evaluations, which Mary put in the chat, then we can get responses for you. And also, if you want another presentation with the ladies, and if they're willing to come back, maybe we could just do a question answer presentation where you guys can bring questions that you've thought up, or maybe a few slides with the information. But it sounds like this is actually really popular. So I just want to thank both Katarina and Jessica for presenting today, and well, Jessica for being present. But we really appreciate you guys being here, and we want to thank everybody for taking their time to be with us. And we hope to see you next Wednesday. The presentation topic will be the 4 H's with IHI. And so, I'm sorry, the 4 M's with IHI. And yes, thank you very much for joining us. And we hope to see you back next Wednesday. Thank you.
Have a great day, everybody.
Have a great day.
Bye.